Hello, everybody. This is Margareta Harris at the World Health Organization headquarters, Geneva, welcoming you to this briefing on global health issues. We have us in the room, as always, the World Health Organization Director General, Dr Tedros Adhanom Ghebreyesus, and to his right is Dr Mike Ryan, our Executive Director for the World Health Organization Health Emergencies Program. Next to him is Nabil Tabal, Incident Manager for the Escalation of Violence in Israel and the Occupied Palestinian Territory. And next to him is Dr. Ana Maria Henao Restrepo, our lead for the Research and Development Blueprint for Epidemics. On Dr. Tedros' left is Dr. Maria Van Kerkhove, Director ad interim for our Epidemic and Pandemic Preparedness and Prevention Program. And next to her, we have Dr. Rogerio Pinto de San Caspar, Director of Regulation and Pre-Qualification. And next to Dr. Gaspar is Dr. Jean-Pierre Niamese, our Acting Director, Global Coordination and Partnership and Quadripartite Joint Secretariat on Antimicrobial Resistance. We also have a large number of WHO experts online whom we will call upon to answer your questions as needed. Dr. Tedros will first give you an update, and then when he's finished his opening remarks, I'll open the meeting to questions. Please use the raise your hand icon to register you have a question, and make sure you've given the name of your outlet and your name, so that otherwise we cannot give you the floor. I'll apologize now to those who missed getting their question answered. We will have to have a hard stop, as our speakers do need to get back to their myriad other demands. But in that spirit, I will hand over now to Dr. Tedros.
Thank you. Thank you, Margaret. Good morning, good afternoon, and good evening. Last week, I was in Sudan, seeing firsthand the devastation that has caused untold destruction, death, disease, and the displacement of more than 13 million people. That includes more than 640,000 people who have sought safety across the border in Chad. Yesterday, I returned from Chad, where I had the opportunity to meet some of those people in Adri on the Chad-Sudan border. I met mothers who had walked with their children for days after their homes were burned, their crops destroyed, and their animals stolen. They left Sudan and arrived in Chad with nothing. When I asked them what they needed, their answer was simple: we're hungry. I also had the opportunity to join a convoy of trucks crossing the border from Chad to Sudan to deliver aid to the Darfur region of Sudan, where many of the refugees are coming from. In the capital, in N'Djamena, I met with the President of Chad, His Excellency Mohamed Idriss Déby Itno, to express my thanks for Chad's generosity in welcoming refugees from Sudan, even though it's putting a huge strain on the host communities and the health system. The international community has not given this crisis the attention it deserves. WHO is working closely with our partners to do everything we can to meet the huge challenges these communities are facing. But what they need even more than the aid we provide is a ceasefire, a political solution, and peace. While in Chad, I also had the opportunity to participate in a high-level conference on the eradication of guinea worm disease. In the mid-1980s, there were an estimated 3.5 million cases of guinea worm globally. Last year, there were just 14 reported cases, and so far this year, there have been just 4, 2 in Chad and 2 in South Sudan. We now have the opportunity to make guinea worm only the second human disease to be eradicated. This incredible achievement is thanks to the dedication of the affected communities, supported by a strong network of partners, especially the Carter Center and the personal commitment of President Jimmy Carter over many years. President Carter will celebrate his 100th birthday in less than 2 weeks on the 1st of October. I would like to wish him a very happy birthday and to offer him my deep thanks for his commitment to making guinea worm history. Thank you, Mr. President. Now to the outbreaks of mpox in Africa. I say outbreaks, plural, because it's important to remember that we are not dealing with one outbreak, but with several, caused by different strains or clades of the virus in different places. The most concerning is the outbreak of clade 1b in the Democratic Republic of the Congo and Burundi, where cases are continuing to increase. The virus is being spread primarily through close personal contact, including sex, and within families through caring for young children, breastfeeding, and sharing clothing or bedding. The response to the outbreak is made more difficult by the context, with insecurity in the affected areas and concurrent outbreaks of other diseases, including measles and chickenpox. WHO is on the ground working to stop these outbreaks. Across 9 countries, WHO has trained more than 1,600 health workers on treating mpox. Tomorrow, more than 33 tons of supplies will be delivered to DRC, including essential commodities for testing, treating, and preventing infections. And in Burundi, WHO has addressed a critical fuel shortage to ensure that WHO, our partners, and the government can conduct their daily mpox response activities at pace and scale. Vaccines are now being deployed, but vaccines alone will not end these outbreaks and are only one part of the comprehensive preparedness and response plan that WHO and our partners are implementing. We are also strengthening surveillance and field investigation, laboratory capacity, home and clinical care, infection prevention and control, and risk communication and community engagement. Implementing this plan depends on a strong partnership between governments, WHO, the Africa CDC, and many others, too many to list. One example of this partnership is the launch of the access and allocation mechanism for mpox, which will increase access to vaccines and other tools for people at highest risk and ensure that limited supplies are used effectively and equitably. This mechanism was set up as part of the Interim Medical Countermeasures Network, established by WHO last year and endorsed by member states. Now to Lebanon, where WHO is working closely with the Ministry of Public Health to respond to the mass casualty event caused by exploding communication devices. These events have severely disrupted Lebanon's already fragile health system. For months, WHO and our partners have been supporting Lebanon to prepare for and respond to mass casualty events. We have trained over 5,000 health workers to respond to events like this, covering more than 2/3 of the country's hospitals. And we supported the government to establish a health emergency operations center, which is proving vital in coordinating the response. WHO has distributed trauma and emergency surgery supplies to supplement supplies that we had pre-positioned in 23 hospitals. Together with our partners, we're working to meet immediate needs, including blood supplies and blood testing kits, and monitoring how the health system is functioning. The conflict in Sudan, the refugee crisis in Chad, Mpox outbreaks in Africa and insecurity in Lebanon are just a few of the many overlapping and intersecting crises in our world. The only way to solve these complex challenges is through close cooperation between countries. At the UN General Assembly in New York next week, I will participate in the Summit of the Future, the gathering of world leaders convened by the UN Secretary General to forge a new international consensus on how to deliver a better present and a safer future. The health highlight of this year's General Assembly is the high-level meeting on antimicrobial resistance to be held next Thursday. Antimicrobial resistance, or AMR, threatens to unwind a century of medical progress and could return us to the pre-antibiotic era, where infections that are treatable today could become a death sentence tomorrow. AMR is caused largely by the misuse and overuse of medicines, making microbes resistant to them and diseases more dangerous and deadly. This is a threat for all countries at all income levels, which is why a strong, accelerated, and well-coordinated global response is needed urgently. This meeting provides a historic opportunity for world leaders to agree on specific actions and investments to address this global threat. Antimicrobial resistance is a particular concern in health facilities, where antibiotic-resistant infections pose a severe threat to the safety of patients. This past Tuesday, the 17th of September, was World Patient Safety Day. This year's focus was on improving diagnosis with the slogan, "Get it right, make it safe." The right diagnosis at the right time is the basis of safe and effective healthcare. Diagnostic errors can lead to serious harm and even death. This can include missed, incorrect, delayed, or miscommunicated diagnosis. As a result of these errors, millions of people experience avoidable suffering every year, putting a huge burden on health systems and increasing healthcare costs. Reducing this risk takes collaboration between health workers and managers, policymakers and regulators, civil society and the private sector, and importantly, patients and their families. Together, we can get it right and make it safe. Finally, yesterday, WHO and our partner FIFA launched a new campaign to raise awareness about concussion in football. Football, like other sports, is a great form of physical activity with many benefits for health. But like other contact sports, including rugby, American football, and boxing, there are also risks, including the risk of concussion and brain injury. The Suspect and Protect campaign aims to reduce this risk by helping players, coaches, and medical staff at all levels of football to be aware of the signs of concussion, to suspect concussion for anyone who sustains an impact their head, face, neck, or body, and to protect anyone with one or more symptoms of concussion by ensuring they leave the pitch immediately. Because no match is worth the risk. Margaret, back to you.
Thank you very much, Dr. Tedros. You have a rich menu of health issues there to stimulate questions, so I won't take take up any more time, except to let you know that we also have our representatives from Lebanon and from the occupied Palestinian territory online, in case you also wish to ask questions of them. The first question goes to Janice Q of Bloomberg. Janice, please unmute yourself and ask your question.
Thanks very much. I wanted to actually ask about the rollouts of the Japanese vaccine in Burundi and elsewhere. But I really guess I wondered if the Japanese vaccine should be prioritized as a treatment for exposed children who we know have a higher chance of dying. And if that LC16 vaccine does require or entail training for health workers on how to use that bifurcated needles and educate parents about the scarification process. I suppose linked to that, if we have any idea, rough ballpark figure of when these inoculations may arrive.
Thank you, Janice. We've got Dr. Anna Maria with us who can answer that question fully.
I will refer to the WHO position paper on orthopox virus and vaccination. In the case of the non-pregnant individuals and immunocompetent individuals, but WHO recommends that non-replicated vaccines like the MVA-BN vaccine and also minimally replicated vaccines like the H616M8 that you referred to are appropriate for use in accordance with the product label information. In addition, for immunocompromised individuals for whom replicating vaccines such as ACAM 2000 or the minimal replicating LC16 is contraindicated, the MVA-BN vaccine is recommended. I must say that WHO also encouraged all the countries using these vaccines to use the opportunity of the delivery to collect additional information on the safety of these vaccines in these populations. And then finally, just to say that countries like Burundi are working towards identifying the high-risk populations, the target populations, and initiating vaccinations as they feel they are prepared, because we are insisting, as Dr. Tedros mentioned, that the quality and the integration of all the measures of control are as important as starting vaccination fast, or even more important. So an integrated approach is what we are preconizing. Thank you.
And Dr. Ryan will add.
Well, no, I just want to have a note of thanks and gratitude to the government of Japan for their very generous pledge and donation, and they've been concluding some agreements with the government of the DRC and working with us, and I'm very pleased that they want to work with us through this integrated comprehensive strategy so we can best use this vaccine on the ground. As Dr. Tedros said, what we're doing here, like with Ebola, is you're trying to break chains of transmission. You're trying to stop the virus moving from one person to the other. There are various ways of doing that. One of the most effective ways is to give communities the means to do that, by being able to isolate or to be able to, as a contact, to self-isolate. You need to be fed. You need to have support while you're doing that. If you're a mother, you need to be able to feed your children. You need to have soap to wash blankets. You need to have new blankets in the case if they're contaminated. So there are many, many things we can do in terms of preventing that intimate, personal spread of the disease. And as Dr. Tedros said, introducing the vaccine gives you that extra weapon in the fight. It allows all of the things you're doing to become more effective by further reducing the spread of disease between individuals, by essentially placing protected individuals in the chain. In a sense, the virus runs out of places to go because you place people who are protected in that chain of transmission. And this is a very effective way to use vaccine, and it also adds to the impact of the overall intervention. So we really are pleased to work with Japan on implementing that strategic approach. It is very important to have vaccines for kids, and I do agree with the journalist. It's really important that when this program is implemented, that we're in a position to be able to vaccinate children. There are ways of achieving that through, even with the MVA-BN vaccine, but that is being approached with the regulatory authorities. SAGE, the Strategic Advisory Group on Immunisation, has made recommendations for the off-label use of that vaccine, depending on certain conditions being met. So everyone is working hard to ensure that children in this outbreak can be vaccinated. But we also have to have due regard for regulatory processes. Rogerio is here for safety, for efficacy, and ensuring that if such opportunities are taken, that we're collecting the necessary safety and efficacy data, and that we always have the health and welfare of the population central to our consideration. So a lot of work has been done at various levels, and we're very pleased to be working with so many partners around the world. As we speak, there are hundreds of partners meeting here in Geneva from the Interim Medical Countermeasures Network. And we have fantastic colleagues in the upstream like CEPI, we're working with Gavi, we're working with colleagues in FIND, we're working with colleagues in national authorities like NIH, NIID in the US, and many, many more. And the minute you start naming people, you forget to name some. But we're very, very pleased that this community is coming together to support Africa CDC, to support the affected governments, to support WHO in delivering on this. One final thing, the LC16 vaccine is not delivered by the same method as the MVABN vaccine, and that does introduce complexity to the training, complexity to the logistics, because the LC16 is classically given the same way previous smallpox vaccination was done, which is scraping intradermally on the skin. And that's quite a skilled technique, and that will take time, and that hasn't been used in vaccination programs for decades now. So to introduce that vaccine would be very important. We thank the government of Japan for this hugely valuable donation. But we have to also integrate that into a comprehensive response, make sure children can be vaccinated, and make sure we can vaccinate using this old technique but very effective.
Thank you very much for that very comprehensive answer. The next question goes to Mohammed Aslan of Andalu. Mohammed, please unmute yourself and ask your question.
Thank you so much, Margaret. My question will be about the Lebanon. How many healthcare workers were affected by this electronic device explosion in this country? Also, can you evaluate these attacks from a health perspective? Can they have a long-term effect? Thank you so much.
Thank you. We'll start with our incident manager, Nabil Tabal, and we may move to our representative in Lebanon. Yeah?
Yes, thank you for the question. So from the figures we have, one health worker have been affected, but not in the line of duty. Over. But the WR might have more detail.
Okay, I think we've got the WR online, our representative. Yes, we have Dr. Abu Bakr online. Thank you.
Thank you very much. I think, as Nabil have said, that so far what the Minister of Health have reported actually is one death of a medical doctor at that time. And but again, since the incidents have been for the last 2 days, I think the Minister of Health is also trying to classify and also review the cases, because there's a possibility that healthcare workers who are not in duty, they may have been affected for this explosions for different devices. And the Minister of Health is keep updating the figures every day, so probably we'll know if there are any other healthcare workers. But so far, what we know is one healthcare workers have died for these incidents. In response to the other question about the long-term effect, as you know, what happened for the last 2 days actually was an unprecedented incident, the explosion of different gadgets, and it's been used not the normal explosion materials, it's been used a different. So it's very difficult actually to know exactly the short-term and the long-term impact of this substance that's been used for the explosions. But I think the expert, and as well as in collaboration also with WHO, now we are trying to study more exactly what happened, how it happened, what kind of material is being used, and how it's affected the people that have already been wounded, which is over 3,000 people, and also 37 people have died so far. So I think we have some work to do to study more, both the security side, but also in health side, how this will have an impact in the short term and the long term impact. But I have to say that this is a new phenomenon. It's a new event that we have not seen before. And I think there's a lot to be learned in the next few days and weeks.
Thank you very much, Dr. Abu Bakr, and Dr. Ryan.
Very
will
briefly, I just
say more.
would like to commend the Ministry of Health in Lebanon. This was an unprecedented event. It came without warning, and the whole health system came under immense pressure very, very quickly. And the work that Dr. Firas Abad and his team at the Ministry of Public Health and others have done over the last number of months with WHO on preparedness for not necessarily this exact event, but for this type of mass casualty event, pre-positioning of supplies, training doctors all over the country, the immediate response, and Abdi Nasser, our country rep, and the team there, our incident management team reacting. These events are always a tragedy, but they're a worse tragedy if you don't get the response right. So I do think the Ministry of Health and Dr. Abad deserve a lot of credit for the way in which an already stretched Ministry of Health that's been through so many different crises, including the huge explosion recently, the economic crisis, so many things. This is a medical system under huge strain. And the fact that they could stand up to this mass event is a testament to the resilience of health workers and the health system in Lebanon. Thank you.
Thank you very much, Dr. Ryan. We now go to Emma Farge from Reuters. Emma, unmute yourself and ask your question.
Thank you. Yeah, actually, that's good timing because it follows on from that question. I was just hoping for a little bit more detail on maybe how other people suffered in Lebanon who weren't directly impacted by the attacks. Were other patients sort of neglected? Can you elaborate a bit more on the kind of impact on the whole health sector of these attacks? Thank you very much.
Thank you. Well, we'll go to Dr. Abu Bakr again. Do you have any more information for us?
Yes, thank you very much. I think as the DG have said, and also Mike Ryan have said that, the Lebanon health system, has already been suffering actually with the multiple crises that the country has experienced in the last few years, economic crisis, social crisis, and also the Beirut blast, among many other issues. And I think now what we are seeing at the current crisis, which has been going on for the last 9 months, since October last year until now, and the health system has been trying actually to address some of those challenges. Of course, the health system in general has been impacted for the current crisis as well as other crises. But I think the resilience of the health system, but also the healthcare workers and the Minister of Health, as well as the WHO and other partners who are supporting, we were able to manage actually to respond some of those crises effectively. For example, in the current crisis since October until now, I think we invested so much to prepare for hospitals. And so we have, trained almost over 5,000 healthcare workers for the advanced trauma management. We propositioned supplies. We did a series of drill exercise in all hospitals to prepare. And I have to say that during the incidents 2 days ago, many of the hospitals have really appreciated the effort of the Minister of Health and WHO actually for preparing the hospitals for this kind of a mass casualty event. And I think most of them actually have already prepared when it comes to the skills and knowledge required to handle the supplies, and every steps need to be taken. And I think that has helped actually to minimize the impact. And that's what helped actually to increase the number of patients that we have saved. And I have to say that, as Mike have said, that Minister of Health has played a very important role to coordinate. There were 100 hospitals in general that has been involved for these incidents. And the Minister of Health has actually coordinated the referral of these patients from one hospital to another hospital to another hospital. But I have to say that this event was unprecedented, and the health system in general in Lebanon have really felt overwhelmed to respond on this crisis.
Thank you very much, Dr. Abu Bakr. Now, the next question goes to Kerry Cullinan from Health Policy Watch. Kerry, please unmute yourself and ask your question.
Thank you, Margaret. Mine is about mpox. I understand from Africa CDC that in Burundi, all cases are hospitalized and isolated. And I wondered about this approach, particularly for treating children, and whether there was perhaps some merit in trying to assist people to isolate in their homes, as in other cases, that's driven disease underground and people haven't wanted to get help. Thank you.
Dr. Maria Van Kerkhove will answer this question.
Thanks very much for the question. So it is really important that cases do isolate, but there are options for where they can isolate. Certainly, if there's an indication of clinical severity, if they have a risk of developing severe disease, it's important that they get appropriate clinical care. So isolation in a hospital is helpful, but we do have guidance out about isolation at home. For people who are presenting mildly, for people who aren't at risk of developing severe disease, home care is completely appropriate. And this is really important that the scabs are covered, that we use good hand hygiene, that the close physical contact between caregivers is done appropriately so that we can prevent onward spread. Also really critical to clean bed linens, clean clothes, etc. And that's very difficult in many different contexts. But home care is something that we advise in many different types of settings. It is perfectly appropriate, again, for people who have mild disease and who aren't at a risk of developing severe disease.
Thank you very much, Dr. Van Kerkhove. Then the next question goes to Belisa Godinho from W Magazine, Portugal. Belisa, please go ahead and ask your question.
Thank you very much. I was at a WHO webinar about Mpox in society. Several cases were presented. Could you elaborate a little more on how the disease spreads? Mpox can be localized to a certain part of the body. Mpox in the eyes, on the cornea. How does this happen? And in the case of infected babies and mothers, not any updates? Thank you.
I think that's another one for Dr. Van Kerkhove.
Yeah, I can start. I mean, what we know about, there's a lot that we're learning about Mpox, but what we can say about the outbreaks and the transmission that's happening right now is we see transmission happening mainly among close physical contact, close intimate contact of people, physical, skin to skin, mouth to mouth. And we do see different types of modes of transmission, including through sex. We see it through the care of caregivers, mothers to children, for example. There are quite a few infants that have been infected. Could happen through breastfeeding. Breastfeeding is very important for mothers and their babies. So there's a lot of different ways that it's being transmitted. And what we're trying to do in the field with partners is to better distinguish the different ways in which this virus is transmitting among children, among adults to children, children to adults, also in the context of sex workers, so that the messaging that we put out there to prevent the spread can be much more targeted.
Thank you very much, Dr. Van Kerkhove. We now go to India, to Ashvin Basinga from Observer Times. Ashvin, please unmute yourself and ask your question.
This is Ashwin Barshinge, Observer Times, India. My question is on Israel-Palestine conflict. With the reference to the provisions of the Part 2 of the 4th Geneva Convention that cover the whole of the population of the countries in conflict without discrimination and are intended to alleviate the suffering caused by the war. What action has the WHO organization taken regarding the violation of the explicit agreement in health between the warring parties? I recall Dr. Richard Peppercorn discussing the terms and conditions of the agreement in previous WHO press conference. Thank you.
Thank you. I think the best, our legal counsel would be the best person to answer this question. I think he's online. Can we get Derek up? Yes. We may have to repeat the question.
Can you see me now?
Yes, go ahead. Do you need the question repeated, Derek?
Yes, please.
Ashvin, would you just paraphrase the question? You were asking about the Geneva Conventions and the violation of those. Is that correct?
I'm repeating the question. With the reference to the provisions of Part 2 of the 4th Geneva Convention that cover the whole of the populations of the countries in conflict without discrimination and are intended to alleviate the suffering caused by the war. What action has the WHO organization taken regarding the violation of explicit agreements in health between the warring parties? I recall Dr. Richard Peppercorn discussing the terms and conditions of the agreement in previously WHO press conference. Thank you.
Well, thank you very much for that question. In fact, it's not the mandate of WHO to enforce international humanitarian law in any situation, including this one. Our mandate is to support public health in emergency situations, which you can see is being done in a number of different ways. I'm not familiar with the particular actions that you are referring to, but there are a range of actions that our colleagues can explain in great detail about how WHO is assisting in the situation. But it's not our role, as I say, to take a specific position on breaches of international humanitarian law as such. I don't know if other colleagues want to expand on the actions which are being taken more generally in the area and to support public health and alleviate the emergency, but I don't think there's much we can add in terms of the specific agreements.
Thank you very much, Derek. We did have the representative, but the line's dropped out, unfortunately. We've got connectivity issues. So I think that really covers the legal position, and we are taking many, many actions to support the health of the people, all affected by the hostilities. And if you've got you want specific examples, we can certainly provide that in writing if you contact us. Thank you. And on that, I think we've satisfied all your curiosity. I don't see any more people in the queue, so I'll hand it back to Dr. Tedros for some final remarks.
Thank you. So thank you to all members of the press for joining us today, and see you next time. Thank you.